Hello and welcome. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 1 of this 3-part CMEOCast podcast series titled Maintenance Therapy of Metastatic Urothelial Carcinoma, Integrating Current Treatment Options into Practice. This podcast series is supported by an educational grant from Pfizer Incorporated, as well as EMD Serramo Incorporated. I am Daniel Petrolak, Professor of Medicine, Medical Oncology and Urology at the Yale School of Medicine. I'm also the co-director of the Signal Transduction Research Program at the Smilow Cancer Center in New Haven, Connecticut. I'm joined today by my esteemed friend and colleague, Dr. Guru Sampavde. Dr. Sampavde is the Bladder Cancer Director at the Dana-Farber Cancer Center and Associate Professor of Medicine and the Harvard Medical School in Boston, Massachusetts. Welcome, Guru.
Thank you, Dan.
Terrific to have you. In addition to the CME credit, today's activity is eligible for ABIM MOC points. Once you complete the activity, provide your ABIM ID and birth date. When completing the evaluation, CME Outfitters will submit your MOC points. You can also claim this activity as a CME for MIPS improvement activity. Over the next 90 days, to actively work to incorporate improvements in your practice presented in today's activity. CMEO will send you a follow-up survey in approximately 3 months. Upon completion of the survey, CME Outfitters will send you confirmation to submit your CMS attesting to your completion of a CME for MIPS improvement activity. Our learning objective for this episode is to evaluate current first-line treatment options, including maintenance therapy for metastatic urothelial carcinoma, and to integrate these as appropriate to practice. Guru, why don't you start us off with a State of the Union metastatic urothelial carcinoma overview?
Thank you, Dan. So for a long time, and even now, the treatment of patients with metastatic urothelial carcinoma has been thought of as two camps of patients, one that's cisplatin eligible, one that's cisplatin ineligible for a number of reasons. And in patients with cisplatin ineligible disease, we have given these patients cisplatin-based combinations like gemcitabine cisplatin, MVAC, or dose-dense MVAC. And what we know is that with cisplatin-based combinations, the objective response rate is in the 50% range, but the median progression-free survival is in the 8-month range, and the median survival is 14 to 15 months. What we also know is that there is a tail to the curve of approximately 15% of patients alive at 5 years, which suggests that we might be curing a small proportion of these patients. Unlike cisplatin-eligible patients, in cisplatin-ineligible patients, we have been giving carboplatin-based chemotherapy historically. With carboplatin-based regimens like gemcitabine carboplatin, which is the community standard for these patients, the median survival is lower than we see with cisplatin, is in the 9-month range. And also, you don't see these 5-year survivors that you see with cisplatin-based chemotherapy. So this has been the conventional first-line combination platinum-based chemotherapy for these patients for a long time, and even now for most patients. And now what we have over the past few years is the advances made with the immune checkpoint inhibitors approved in patients with progressive disease post-platinum-based chemotherapy. And these are PD-L1 or PD-1 inhibitors. The PD-L1 inhibitors are atezolizumab, avelumab, and the PD-1 inhibitors are pembrolizumab and nivolumab. Pembrolizumab remains the only one approved in this setting of progressive disease post-platinum, with the evidence backing up with a phase 3 trial. The other drugs are all approved based on phase 2 data. So this has been the state of the field in a nutshell in patients for first-line disease and second line in the second line post-platinum setting. And we will talk about this some more, as you know, with the recent advances with avelumab in the switch maintenance space. Yeah, so Dan, you were involved in Javelin Bladder 100 trial. Before we get into the data, can you address the goals of maintenance therapy?
Well, thank you, Guru. I think it's important to note that when we're thinking about maintenance therapy, we're giving chemotherapy initially upfront. So these are selected patients. So what we're trying to do is reinforce and sustain that favorable clinical state that we've achieved after we've gotten the disease under control with chemotherapy. So we're looking to further reduce the tumor burden, to suppress regrowth of the tumor, to potentially extend relief from tumor-related symptoms such as pain or weight loss, and of course, most importantly, to prolong overall survival. So maintenance therapy can be a continuation of the original agent as part of therapy. We've seen that in some situations where we give chemotherapy. And then there's switch maintenance, which is the sequential use of new agents as maintenance therapy in patients with various tumors. So let's talk about the Javelin 100 trial study design. So this was a randomized study where patients who had unresectable, locally advanced or metastatic urothelial carcinoma, they had to achieve with chemotherapy a complete or partial response. And then they're switched to, this was after 4 to 6 cycles of either carboplatin or cisplatin-based chemotherapy. 700 patients were entered in the study. And then they were randomized after 4 to 10 weeks post their initial treatment to receive avelumab at 10 milligrams per kilogram Q2 weeks plus best supportive care versus best supportive care alone. And the primary endpoint in this study was overall survival in all randomized patients, as well as in the PD-L1 population. And the secondary endpoints were progression-free survival by RECIST, the objective response rate by RECIST, as well as safety and tolerability. We've seen from the first analysis of the Javelin data that avelumab will improve median overall survival in the all patients that are treated. So for those patients who received the checkpoint inhibitor plus best supportive care, their survival was 21.4 months versus best supportive care alone, which was 14.3 months. That's about a 7-month difference in the median. The hazard ratio is pretty impressive. It's 0.69. If we look at the PD-L1 population, the median has not yet been reached in the avelumab arm, whereas best supportive care, it's 17.1 months, and the hazard ratio is slightly better at 0.56. So again, a little better in the PD-L1 population, but most importantly, all patients do seem to benefit from this treatment. If we look at median progression-free survival in the overall population, best supportive care alone plus avelumab is 3.7 months versus 2.0 months for best supportive care alone. This is, in my mind, not surprising because we know that checkpoint inhibition therapy really doesn't have that great effect on progression. It's the survival that really is the different issue here. If we look at the types of side effects that we've seen in these patients treated with avelumab plus best supportive care, this is really not much different than what you would see with any standard checkpoint regimen. Fatigue, liver function abnormalities, urinary tract infections, diarrhea, arthralgias, all these are known immune-related side effects, and they seem to be at a slightly higher rate than what you would see in the overall general population. But really nothing that's significantly different. There's nothing that's glaring when you look at this in terms of all types of checkpoint therapy. So we have a variety of different checkpoints that are approved, in fact, 5 for urothelial carcinoma. Guru, although pembrolizumab is not approved as maintenance therapy, there is data. Can you talk about the switch maintenance studies that have been done with pembro in patients with metastatic urothelial cancer?
That's right, Dan. So pembrolizumab, although we don't have a phase 3 trial, we have a randomized phase 2 trial. This was conducted by the Hoosier Research Group, led by Matt Galsky, which looked at maintenance pembrolizumab versus placebo. It was placebo-controlled, and this was similar to Javelin Bladder 100 with some differences. So this trial allowed up to 8 cycles of first-line platinum-based chemotherapy and allowed switch maintenance therapy to pembrolizumab or placebo within 2 to 6 weeks after the last dose of chemotherapy. It was a small trial, just over 100 patients. And as you can see here, patients received pembrolizumab versus placebo. And the trial also did allow a crossover of patients who progressed on placebo that could be then crossed over to pembrolizumab at progression. The primary endpoint was progression-free survival with secondary endpoints of overall survival. And actually, the trial was positive because pembrolizumab did improve progression-free survival compared to placebo, and the hazard ratio was quite robust at 0.65. Now, survival was not extended in this trial, but survival was a secondary endpoint. And therefore, we consider this to be a positive signal in terms of improvement in PFS, with the median PFS 3 months
for joining us, and I'd like to thank the audience today for joining us in this presentation.